Good afternoon, everyone, and welcome to the webinar, COVID-19 in Rural America. I'm Carly Lovelet, the manager of the Clinical and Rural Health Research Department at the St. Lawrence Health System. And today you're going to be hearing from Dr. Kadar, rheumatologist and COVID-19 treatment team member at St. Lawrence Health System. This program was developed by St. Lawrence Health System Clinical and Rural Health Research Department in collaboration with the Patients Program at the University of Maryland, Baltimore School of Pharmacy. This educational series is funded through a Patient-Centered Outcomes Research Institute Eugene Washington Engagement Award. And although this webinar is specifically focused on COVID-19, we're also offering additional webinars where you can learn about patient-centered research as well. We have details on upcoming events towards the end of this presentation. That said, I can't move on without also thanking the multiple patients, nurses, healthcare providers, administrators, and community members who have worked really hard with us over the past year to bring the patient and community voice into our research program and to develop these community webinars. All that being said, it is my absolute pleasure to welcome Dr. Eyal Kadar, St. Lawrence Health System rheumatologist. Dr. Kadar has also been a part of the small group of healthcare providers that treats patients who contract COVID-19 in our region. And in addition to this effort, he is also our lead clinical research investigator. I've worked with him closely over the past 5 years to offer his patients clinical research opportunities in areas like lupus, rheumatoid arthritis, and psoriatic arthritis. Most recently, he has also been an investigator on our COVID-19 clinical trials. One of his chief interests is in developing strategies for improving healthcare delivery to rural communities, and I definitely think you're going to catch a glimpse of his passion for this topic during his talk today. So Dr. Kadar, my friend, the floor is yours.
We have several learning objectives for today's talk. The first one is really one of the biggest ones for me, and that's why I listed it first. The question, why is the pandemic striking so hard in rural America? So much comes down to this question. And I'll talk about that more as we go on. Other objectives, what is the pandemic telling us about health and healthcare disparities in rural America? What can be done to improve these disparities? And finally, how are we treating COVID-19 here in the St. Lawrence Health System? So why is the pandemic striking so hard in rural America? To begin with, let's talk about some causes of spread of SARS-CoV-2, just in general to start, and then also in rural America. So in general, SARS-CoV-2 is often spread by people who are not adhering to public health guidelines. You see a picture here of somebody who is spraying droplets and aerosols from her mouth. If this person were to be infected with COVID, this person standing in front of her who is inhaling those droplets and aerosols would be at high risk. COVID is, we know, spread in this way, so wearing a mask and having people around you wear masks is one of the most effective ways that we can prevent the spread of SARS-CoV-2. So people not wearing masks, people not adhering to social distancing guidelines, not being more than 6 feet away from the closest person outdoors, spending time in crowded rooms, also hand washing. The ability to transmit COVID-19 through contact and through fomites is not what we initially thought it might be, but nonetheless, washing your hands is very important so that you don't infect yourself. And so adherence to all these public health guidelines is essential, and when people don't adhere to these guidelines, SARS-CoV-2 can spread. In rural America in particular, we have a lot of potential SARS-CoV-2 or COVID-19 hotspots. Prisons. If there's an outbreak in a prison, it can be disastrous for a community. This is actually one of my great fears. Our county is now struggling badly with COVID-19. The largest hospital in my county has barely any beds as I speak. And it is, as a member of the COVID-19 treatment team in my health system, I am always concerned that one of our regional nursing homes or prisons in particular will have a large outbreak. So hotspots in rural places, prisons, nursing homes, meatpacking plants, etc. Social gatherings are a big way in which SARS-CoV-2 spreads. If you put somebody with the virus, who's infected with the virus, into a room full of crowded people who are not wearing masks, you can imagine that that's going to have the potential to be to infect a lot of people. There's a term called super spreading events, where one person or several people can infect a lot of people at one time. And a setup for that is having a crowded room with stagnant air, with air that's not moving around, i.e., that's not moving and it's circulating well enough, i.e., a crowded, closed space. So jobs, people who have jobs that don't have the option of working remotely. I'm talking about minimum wage jobs, jobs with lots of contact with the public. Those are the jobs that are more common in rural America. And so that is a potential cause of spread of the virus in rural America. Additional challenges faced by rural America. You've got a lack of infrastructure. And by that I mean testing capacity, personal protective equipment, the doctors to treat COVID-19 in the first place, hospitals, financial. You've got a poorer, sicker population. And when you have this combination of poor medical infrastructure, underfunded hospitals, that goes under the financial tab here, and just a population that's poorer and sicker in general, you have a terrible recipe for disaster in the pandemic. And that's what we're seeing right now. We're seeing overrun, under-resourced rural hospitals. In some places, doctors and nurses who have been infected with COVID-19 in rural areas, and I'm thinking of North Dakota in particular, where I just read an article about this recently, they're being asked to work so long as they remain asymptomatic. These are providers with COVID-19. That's how under-resourced parts of rural America are in the pandemic. And what I was saying, by health, I'm referring to disease burden. When I talk about health disparities, I'm talking about having a sicker population in general. And rural America is by and large sicker than non-rural America. And I'll show a slide that will better demonstrate that later in the talk. And then I'm talking about health care disparities. By a health care disparity, I'm referring to a disparity in access to care. That means that you have less access to doctors, to hospitals, to testing capacity, to personal protective equipment, everything that's at the top of this slide. Everything on this slide is very interrelated. So let's talk more about health and healthcare disparities in rural America. Once again, health disparities refer to a different disease burden. If group A is sicker than group B, there's a disparity between those groups. And again, in rural America, we have an older, sicker, poorer population with higher mortality. Health care disparity, again, access to medical care. These disparities were already very bad before the pandemic struck. But now, in the COVID-19 pandemic, people who can't get to their doctors, who are getting COVID-19, are getting sicker. People who can't access hospitals that are overrun with COVID-19 patients have less access to medical care. So you've got this region of the country, this sector of the country where 1/5 of its residents live, 60 million people, and things were already bad. And now because of the pandemic, for a variety of reasons, this already bad situation is just getting worse. So here's that slide I told you I would show you. If you look at mortality rates, all-cause mortality for the years 1999 to 2015, you can see that consistently the age-adjusted all-cause mortality rates in rural America have been above those of urban America. And again, this goes back to a lot of factors. Patients, rural America being older, being poorer, having less access to healthcare disparities. There are a lot of diseases that are more common in rural areas, ranging from diabetes, obesity, high blood pressure, emphysema, to many more. And again, how the pandemic has worsened these health disparities. How has it made rural America, or is it threatening to make rural America even sicker? Well, health isn't just about having doctors and having medicines. Health, and there's another slide coming up about this, is based, your good health is based on a lot of factors that are called social determinants of health that go beyond medicines and doctors. To be healthy, you've got to have a good job. If you're a working age person, you've got to have access to healthy food. You have to have enough money to pay your bills. And so when you have a pandemic like COVID-19 that has led to increased unemployment across the country, and of course in rural America too, now you have more people who are unemployed. You have, as a result of that, increased food insecurity. People have less money to pay for food, and increased poverty. So you take this pandemic, you hit a vulnerable population with it, and multiple social determinants of health that have already been bad just get worse. Here's a slide I want to show you. It takes more than medicines and doctors to be healthy. Everybody knows that. I'm not telling you anything you don't know. We all know that. Having the right circumstances is important. Having a decent place to live, having healthy relationships, having the ability to have transportation. If you don't have public transportation, and in much of rural America, there really is limited public transportation. There are limited public transportation options. It's important to have a car. And yet the majority of people who live below the poverty line do not have a car. You have to have not just a good place to live and good social relationships and transportation options. You've got to have the educational opportunities, and you have to have those opportunities for your kids so that it's possible to get ahead and get a good job. And Michael Marmot said, if you want to understand why health is distributed the way it is, you first have to understand society. And I could not agree more. You have to understand, as a doctor, if you're doing a good job, you have to look far beyond the labs and the imaging studies for your patients. You've got to listen to their stories, know what their social circumstances are, and try your best to understand what their particular social determinants of health are. So I love this quote, and I think it's a very wise one. So some questions. There is a recent letter I wrote to President-elect Biden and his recently assembled COVID-19 advisory board. It's on my website if you want to read it, www.ruralamericaandcovid19.com. It's under the blog section, and it's just titled A Letter to President-elect Biden. And I asked some of these questions in that letter, things I'm concerned about. One of the things I ask in this letter, and that I'll mention here that I'm very concerned about, is that rural areas, which have been under-prioritized in so many areas of healthcare, in all areas of healthcare, for so long now, that they'll again be under-prioritized when we have a vaccine, that we will get a vaccine late. As a member of our health systems, the St. Lawrence Health System COVID-19 inpatient treatment team, one of my big jobs is helping us get medication options for our patients, in the form of bringing in clinical trials and other. And I tried very hard to get remdesivir for a long time. And finally, we got remdesivir, but it was late. We got it later than the cities. And I'm worried that this will happen again with vaccines. Will rural deaths be properly counted relative to non-urban areas? We know that any COVID-19 death count is probably an undercount, and that's been talked about a lot in the press, and that's correct. A lot of people who have died at home and who will die at home, we haven't counted them properly. But in rural America, where there's no research infrastructure in pretty much all of rural America, our county here is a rare exception to that, but there's very little research infrastructure, clinical research infrastructure in rural America. Will there be the apparatus in place to properly count all the deaths that happen, but which don't happen in hospitals? It goes beyond clinical research. It just goes to resources in general. Will there be the resources in place to make sense of what's happened when the hospitals themselves are so overrun with COVID cases and already have such a hard time in handling those cases? So will we ever know the true mortality rate from COVID-19 in rural America? I don't know. I hope we will, but I'm not sure. So addressing disparities, can the COVID-19 pandemic serve as a catalyst for change in rural healthcare? It must. This is like a 9/11 moment, some have said, for rural healthcare, and they are right. If this does not shine a proper spotlight on the needs of rural Americans and of the disparities in rural healthcare, then nothing can. So it must. How can health and healthcare disparities in rural America be improved? There needs to be more investment in a lot of areas, starting obviously with healthcare infrastructure in our hospitals, in training providers for rural practice. That goes from continuing efforts to train primary care providers for rural practice to developing systems for training subspecialists for rural practice. As a graduate of the internal medicine subspecialty training system in the US, I can tell you there's very little national effort to train rural subspecialists. There's some, but very limited. Clinical research, technology, and the right kinds of technology, telemedicine, but knowing the limits of telemedicine, not using it as a crutch, using it as something that helps, but that you don't lean upon exclusively. Rural America itself, we have to make, we've talked about this, the importance of a person being well before they can be healthy. We have to invest in education, which leads to better jobs. We need to invest in jobs. More businesses need to come and settle here. Good housing, every social determinant of health, they all must be tended to in this in this effort. Where should the money come from? Everywhere. from government to corporate America to foundations to private donors. And I'm talking about private donors from billionaires down to people like you and me who are able to provide what we can. How should it be spent? Tough question. I'm not going to venture a proper answer for that, but I'll say that investment is needed in many areas. And a lot of smart people will need to come together to think about how to efficiently and properly spend this money. It'll all start with the commitment to spend it in the first place. Treating COVID-19 in the North Country. How do we treat COVID-19 in the hospital setting? It's interesting. Just today, the World Health Organization put out a recommendation against using remdesivir, which is on this slide. But I left it on the slide because we still do use remdesivir in certain situations. There's a big study in the US, the ACT-1 study, where even though remdesivir did not have a mortality benefit, it did show a significant reduction in the time to clinical recovery by about 30% for patients. So I don't know that the door has been shut on remdesivir. We also have other studies like ACT-2, where remdesivir in combination with a drug called baricitinib lower the time to recovery by a day relative to remdesivir alone. So that's a small victory as well. So remdesivir has a limited role still, I believe. It may actually, in combination with the right drugs that we need to still keep finding, may have an even larger role. Steroids, there's a study called the Recovery Trial that showed a particularly meaningful mortality benefit in patients who are intubated and who get steroids. Patients who are on supplemental oxygen, much smaller benefit, but you got to be careful. Patients who were not on oxygen in that study actually did worse and had a trend towards higher mortality. So you have to know when to give these meds. It's really important to know the clinical data. If you're going to treat COVID-19, you do have to have a sense of the data from the big trials. There's no other way to do it. And you also have to have a lot of experience in just managing the patients. That combination is the way to do it. Anticoagulation. COVID-19 is known for causing blood clots, heart attacks, strokes, pulmonary emboli. So our team has an anticoagulation protocol. We choose who gets anticoagulation, who gets lower dose, intermediate dose, or high dose, otherwise called therapeutic dose anticoagulation. I won't go into how we make those decisions here. It is important to have that decision made by a team, and we have a daily rounds in order to make that decision for every patient in our system every day. Experimental medications, these can potentially make the difference between life and death. And we're lucky to have a thriving clinical research program in the North Country. We were in the Impacta trial for tocilizumab earlier in the year. We were the only rural site in New York, and I believe probably one of the only rural sites anywhere in that study. We are now in the ACTIV-2 study that's part of Operation Warp Speed, which is an outpatient COVID trial, and we are about to bring in the next few weeks a very high profile and high potential inpatient trial as well. Supplemental oxygen. This is a big part of treating COVID patients. And then mechanical ventilation, knowing when to intubate a patient and how and when not to, not intubating too early. And I won't go into how we make those decisions here either. It's a subject for a longer talk, but picking the right form of mechanical ventilation, but even more importantly, knowing when to do it and when not to, extremely important. How is the St. Lawrence Health System handling COVID-19? One of the biggest things I can talk about, one of the most important things we've done, in particular early on in the pandemic, was we had small teams of generalists, a small team of generalists. We had only 3 physicians on the team every day for the first 7 months of the pandemic. We have a larger team now, which is great, but I want to talk about the small team because it's something that a lot of rural areas, I think, can replicate. We had myself, and my role was to, my background is I'm a rheumatologist, but as a rural rheumatologist, I developed an interstitial lung disease clinic to meet an unmet need in this community when I got here. And then when COVID came, this mixture of pulmonology and rheumatology skills was an excellent one for managing the virus, because it's a pulmonary virus, but a lot of the medicines we use to treat it are medicines that are immune modulators and that are most familiar to rheumatologists. So that's my role. We have an excellent infectious disease physician who's an excellent generalist, even by ID standards. And we have an excellent team of hospitalists who are also all great critical care physicians. And so who are excellent generalists within the field of hospitalist medicine. So that small team approach is a very potent one for various reasons. When you have a small group, what I've found is that there's a real natural dialogue and conversation that happens that you don't always get in larger teams. People feel comfortable asking questions, disagreeing with one another, and conversation flows in a very natural and effective way. And if anybody on this call, and I'm sure everyone knows at least somebody in this boat, you must know someone who has gotten sick and somehow they've gotten 5, 6, 7, 8 subspecialists onto their team. And somewhere along the way, it started to feel like the big picture has gotten lost. All of us know somebody like that. As a physician, I know many. And I was struck, and I'm still struck by how effective a model this was. And I really think it should be looked at beyond just COVID, beyond just rural pandemic responses. In general, this may be an excellent model that could be applicable far beyond rural America. So that's been very effective for us. A hub and spoke model. What we do is we transfer, and you see the diagram on the right here, we transfer everybody in our health system. We are a 3-hospital health system. Every patient from one of our smaller hospitals who has COVID gets transferred to our hub hospital, which is Canton Potsdam Hospital. That's where our inpatient COVID-19 treatment team works. That's where all clinical trials get run out of. And we're able to channel to channel all patients towards this area of this hub of high resources. And that's been a very efficient and effective care delivery model for us. Clinical trials. So, as I said, we've already run several. Finished one. We are in another and about to start another clinical trial. And these provide, I can't tell you in strong enough language how important this has been to me, at least. And I'll just say, when we got our first clinical trial, and it was very expensive to get, we had been purchasing the medication called Actemra, which we ended up being in a clinical trial for up until that point. And it had been a hardship for our hospital. It was a lifeline for our patients. It was also a lifeline for our team and our system to have an option for our patients. Both, it reduced the financial burden, and it also opened up an option. The trial we're going to get goes beyond that. The drugs that we're going to have access to are drugs that we couldn't otherwise get, that are only available in the context of this clinical trial. And so to have clinical trials opens up options for patients, options for physicians. It can help struggling hospitals from a financial standpoint. It can be helpful on so many levels. And in an under-resourced rural environment, it can mean everything to a treatment team. It can mean very, very much. How are we handling the COVID-19 pandemic? Lots of work from lots of people. And I can't even come close to acknowledging them all. Treatment goes so far beyond having medications in place for your inpatients. You've got to secure PPE. You've got to have adequate testing capacity. You've got to make your inpatient environment safe. You've got to make your ER safe. You've got to make your outpatient sphere safe. You have to do so much to prepare a health system for this. And so many people in our system did just phenomenal work in getting us ready, and keeping us ready. How are we handling COVID-19? I'm going to close here. Let me make sure this is toward, yep. I'm going to close here with a slide about clinical trials, because I want to emphasize again the importance of having clinical trials in rural America. So many of the guidelines for treating COVID-19 are for drugs that should only be treated should only be used per the national guidelines in the context of a clinical trial. Those guidelines just show how this disconnect between national medical societies and academic medicine in general and the on-the-ground reality in rural America. And this is a theme. There are diseases like this where for this disease, the patient should only be managed in a center of excellence. How does that help a rural patient in a small county where the closest such center of excellence might be 6 or 7, 8 or 9 hours away? There are diseases like that from my county I could give you examples of. I'm not going to in this talk, but there are plenty of examples for that in my own county. It doesn't help you. You've got patients who don't have cars, who could barely get to their primary care docs. So to make those recommendations just shows not that anybody's bad, but that there's a disconnect and that there's a systems level problem. There's a failure to see rural healthcare, a failure to see rural America. And I've written about this a lot, and I'm blogging and I'm podcasting a lot about this on my website, and I'll continue to delve into this disconnect because it's such a problem, such a core problem, and I think it explains a lot of why rural American healthcare has been allowed to languish so much. So research. If you're going to recommend that places only give X, Y, and Z drugs in the context of clinical trials, you have to have a sense of what things are like on the ground. We don't have research in the vast majority of rural sites. And so our health system is lucky in that regard. We do have a robust COVID-19 clinical trials program. And it is my hope that we can help replicate this model for other rural sites going forward. It's not going to happen, I don't think, in this pandemic. It takes a long time to build clinical research knowledge and infrastructure. We were lucky enough to be doing this for 5-6 years before the pandemic struck, so we already had our system in place. But to get ready for the next pandemic, developing clinical research infrastructure in rural America is going to be a very important part of the puzzle. It's going to be essential, I think. So I'm going to turn this over to Carly Lovelet, and thank you so much for listening today. I appreciate your time.
Thank you, Dr. Kadar. That was really great. Before we open up to questions, I did want to mention that if you're interested in attending more events like this one, please check out the clinical research webpage, where I'll be posting registration information for more upcoming events. Our next webinar will be part 3 of our 3-part series on patient-centered research, and that's called Learning Together, Leading Together, Shaping Patient-Centered Research in the North Country, and I hope you can join us for that. We'll also be offering additional COVID-19 webinars in 2021, and we'd like to tailor these as much as possible to the interests and to the needs of our community. So please fill out the community survey to help us decide what topics to cover during these upcoming sessions, and a link to the survey can also be found at the clinical research webpage. So Dr. Kadar, we do have some really great questions for you. I'm going to start off by asking, what are the main reasons for the uptick in COVID-19 positive results in the St. Lawrence County and the surrounding area?
I think it's largely the result of inadequate adherence to public health measures combined with spread coming from other places. Whenever the cities we're not close to any city, but nonetheless, we were 3 weeks behind New York City in March. And whenever the cities in New York start to see upticks, we eventually see an uptick as well. So it's a mixture probably of travel from people coming from out of town who have the virus, coupled with inadequate adherence to public health guidelines on the part of some. We're pretty good as a county, actually, at wearing masks, but like any county, we're not perfect. We still have, we have had over the past month, open restaurants, lots of social gatherings, and I suspect it's a mixture of those two factors.
Great, thank you. We do have one person raising their hand. So before Kylie, you answer more questions in the chat, I am gonna allow Kathy to unmute herself. So you should have a button on your screen that will allow you to unmute and ask a question now, Kathy.
Okay, I have a question about viral load. I don't understand how a certain amount of virus could come into your, nasal passage, body, however it gets there, and there would be no immune response. And yet beyond that titration level where it turns pink, you're fine. But beyond that, you have a full-blown deadly case of COVID.
Sure.
How is it that the body what is the body doing with the small particles it might be exposed to and not responding to?
That's a great question. There's no great answer to that. I will say that just about on the subject of viral load, one of the keys to developing a good vaccine for COVID is delivering enough viral antigen to stimulate a proper immune response. When somebody develops antibodies to COVID-19, they have received enough of an exposure to the virus for their body to mount those antibodies. Now, as far as why some people are asymptomatic and why others get sick, it would be great to pin it all on comorbidities and saying that only older people get really sick. We know older people are more likely to get very sick and more likely to die from COVID. That we all know. But COVID surprises us all the time. An older person who you think won't do well does okay. And a very young person who's pretty healthy does very poorly. So there are a lot of questions to answer about genetics, susceptibility genes, other questions of we know, for example, that the type 1 interferon system, and I won't go into the details of that, plays a role in COVID, and dampening that system can be potentially a bad thing. There are 2 excellent papers in Science from, I believe the date is September 24th. They're twin papers that go into that, but it's complex. I don't have a great answer. I won't venture one. We're learning more all the time, and hopefully we'll have better answers to that question in the coming months to years.
Thank you. The next few questions are about vaccines. The first one being, what specific challenges do rural counties in the North Country face in getting vaccines distributed? And what is St. Lawrence Health System doing currently to prepare for that rollout?
The challenges, if this is going to be anything like the distribution of remdesivir, what will happen is there will be a statewide distribution system, and the cities will get priority and rural areas will be backburnered. That sounds very cynical, but at least for us, that's what happened with remdesivir. I don't know that that's what's going to happen, but I suspect that's what's going to happen, that there will be a disbursement to the state, and the state will determine who gets the vaccine, and places like New York City will be prioritized because they have more numbers. I think that's the wrong approach, but it's likely what's going to happen. How will other challenges? Other challenges beyond just working with with regional distribution systems and all the red tape that comes with doing that. For Pfizer's vaccine, which requires storage at -94 degrees Fahrenheit, which is -70 Celsius, or lower, not breaking the cold chain in transportation, it may be an issue. It's tough to get a vaccine that's got to stay that cold all the way to a place like the North Country without anybody breaking the cold chain. Everybody transporting that vaccine has to have an ultra cold freezer, which costs $10,000 to $15,000. So you've got to make sure the infrastructure is in place. You have to make sure that rural recipients of the vaccine have the money to pay for those freezers. Some practices and hospitals that are doing well, it's no big deal. But if you're operating at a loss, it may be a big deal. For us here in the North Country, we're lucky to be in the St. Lawrence Health System. It's a big, thriving system. I have no doubt we'll have no problems buying the freezers, but the cold chain on the way to us may be an issue for that vaccine. Moderna's vaccine, on the other hand, should be easier to transport. It's another mRNA vaccine, but it does not require storage at or below -70 degrees Celsius. Now, how the St. Lawrence Health System is getting ready, I don't think they can do anything until we first hear that a vaccine is available and that there are plans to distribute it to New York. And even then, if my prior experience with the remdesivir is any guide, we won't have much say in the matter. What I am doing personally is I'm writing letters. I told you I wrote that letter to President-elect Biden. Anybody on this call who reads it and wants to spread it far and wide, do it. Because we need to get it to President-elect Biden and his team so they can read about what's going on in rural places. There's no member of rural America on that 13-person board. That's a problem. And they're not going to see rural America unless we knock on their doors loudly and clearly. So that's my long-winded answer to that question. And Carly, you said you had another question.
Yep, a couple more about vaccines. Next we have, are you seeing any skepticism to vaccines in the North Country, similar to what you'd see in other rural pockets of this country?
Of course. I work in a politically conservative county. Anything that you've seen attitude-wise in other parts of rural America that are conservative, I've probably seen it. So sure. And what I do is I work to have a dialogue with and educate all of my patients about what I know about the virus. And that's just based on my experience treating this virus 7 days a week, most of the last 7 months. We have had a few lulls where we've had some breaks, but fewer lulls than active days. We've had a lot of experience now. And as someone who's the principal investigator on all of the trials we've had and currently have for the COVID-19, in our health system, I talk to them about what we know in the literature about the virus. I try to dispel myths in the media. Another thing I mentioned in this letter to President-elect Biden is that not only are there no residents of rural America on that board, there are no full-time clinicians who are treating the virus in a longitudinal way. And I think that's a problem because this misinformation there's been so much misinformation about the virus that it's sadly become politicized. Now, I'm a very non-political person. I focus on science and people. And I really think that if clinicians, if working doctors who see the virus had gotten more of a national voice and had more of a local voice from the beginning, if they worked in conjunction with our public health experts, I really think that we could have put a dent in this misinformation campaign and saved some lives. But you almost never see a doctor who's treating COVID-19 talking about it, either nationally or regionally or locally. I mean, it's amazing how little of a voice the people who treat this thing actually have. And so when you talk about skepticism about vaccines or the virus in general, I think that's a huge problem. And in rural America, which has been left behind for so long, why should a rural American listen to voices that come to them through water? They're hearing from people who don't have who don't have their feet on the ground here. And I hear this from patients. I'm not just asking this question rhetorically out of a vacuum here. This is based on stuff I've talked to people about. A lot of people don't feel heard by the elites, for lack of a better term, in American medicine and in government. And so when those people start talking about the virus, it doesn't have much weight for a lot of people. And it creates a terrible vacuum in which people who want to or don't want to, but who for whatever reason are spreading misinformation, it creates a space for them to enter. And I really think we could have combated this by having the people that rural communities trust speaking to them more clearly in the media from the beginning. So another long-winded answer. You can tell I'm not great with time, but yes, I'm seeing a lot of skepticism, and I'm working on a micro level to combat it. And I'm now trying through my website, my blog, my podcast, to create a voice that rural Americans can listen to, and in particular my community can listen to, that resonates, that combats misinformation more on a macro scale, on a macro level.
Well, I can't speak for the entire community, but I will say that I appreciate all the work that you've been doing during this pandemic. Vaccines are definitely the hot topic. We have one more question about vaccination. Is there any evidence that the virus is mutating so that a vaccine would become less effective?
The most common strain circulating in the world now is the D614G strain. The short answer, no. We are confident that the vaccines, such as those by Pfizer and Moderna, will be very effective for COVID-19. Both of those vaccines are looking to be not only very effective, but, and I'm knocking on wood as I say this, safe and likely to create more sustained immunity than we previously thought, perhaps 10 years or longer. And if that's true, that's just wonderful. All viruses mutate, but the vaccines that we have and the sense from virologists and immunologists is that the virus will not mutate out of control beyond the vaccines that are currently in development.
All right, thank you. One last question to close it off here today, very timely. What is your advice regarding gathering for the holidays?
Don't do it. You've got a rapidly escalating virus. 80% of rural America is in what is called the red zone, which means more than 100 people, more than 100 new COVID cases per 100,000 in the population for the past 7 days. Our county will probably easily meet red zone criteria at the end of this week. And we know, looking at countries who have done a good job and states which have done a good job or a better job at least at flattening the curve, when people aren't allowed to congregate in groups, when things are shut down, bars, restaurants, and Greg Healy, a colleague of mine, and I talk about this on a recent podcast, nobody wants those businesses to suffer. There should be help given to those businesses during these tough times. But to flatten the curve, you have to wear masks, wash your hands, and socially distance. And I'm going to practice what I preach. Thanksgiving is my favorite holiday. Nothing I love more. It's the best. And I love it for the people I see and the big dinners, the big turkey dinners, for everything. It's just so great. It's just an incredible holiday. And I'm going to have holiday Thanksgiving this year with just my nuclear family. It's just going to be the five of us, same group that's been quarantining together for so long now. So I'm going to practice what I preach here. And here's some hope. Vaccines are coming. They will reach rural America. We will never live, I don't think, without COVID, but we'll have a world where we can coexist with it much more safely, and in which we will be able to see our families during Thanksgiving and all holidays. I'm confident of that. I hope I'm not wrong, but I'm in saying that here, but I'm confident of that. But in the short term, we have to hunker down and do the right thing, not just for ourselves, but for everybody. If we all do this together, we'll flatten the curve and we will save a lot of lives. And so for this holiday, at least, with COVID-19 rising in St. Lawrence County, wear your masks, wash your hands, socially distance, and for the holidays, stay home and celebrate with those with whom you've been quarantining. That's my advice.
All right, well, that will close it out for today. Thank you, Dr. Kadar, for your time, your insight, all of the work that you've put into this, and of course, your words of wisdom. Everyone, please stay safe and have a wonderful day.